But towel clip can also be used to hold a flail segment of a flail chest. And very commonly they ask you, how do you define a flail chest? And invariably you keep on saying multiple fractures, etc., etc. The definition is not that. Try to understand this. Multiple fractures of single or multiple ribs with or without paradoxical movement is called as a flail chest. That's the definition. Multiple fractures of single or multiple ribs with or without a flail, with or without a paradoxical movement. This is called as a flail chest. Now try to understand what I'm trying to say. If I've got one rib fractured in one place, because this is the X-ray that in third PPS I was shown. There was a fracture in the second rib, fracture in the third rib, fracture in the fourth rib, fracture in the fifth rib, all the two ribs. There was a single fracture. Okay, and this is what the question he asked me, is this a flail chest? The answer is no, it's not a flail chest. It's a fracture ribs. Now let me explain to you the other option. If you show an X-ray with one single rib fractured at two places, this is a flail segment and also defined as a flail chest. But here you may not get a paradoxical movement. So single rib, multiple fractures is a flail chest. If I get multiple ribs fractured at more than two places, it's a flail chest definitely. Now when you have a single segment fracture at two places, that is called as a flail segment. What happens is that when you get a flail chest, the bucket handle movement suffers. The bucket handle movement transmits the force of the rib from the posterior condyle to the sternoclavicular joint, and they move as a bucket handle. So during inspiration, the bucket handle moves upwards. During expiration, the bucket handle drops down. Now try to understand moment that bucket is broken at two places, the handle. When you lift on either side, that handle will never move. The broken segment will not move. Just imagine if I've got four ribs fractured at multiple places, each rib at two places, a whole segment of flail segments do not move at all during inspiration and expiration. So this in turn falls back, lags behind when the patient tries to take a deep breath because it doesn't move at all. So the paradoxical movement is not an active retraction of the rib, but the non-movement of the flail segment. Try to understand what I'm saying. Paradoxical movement is during inspiration, the chest wall goes inside. That's what you teach. But no, it's not. What happens that segment which is flail does not move at all. He remains back, but the rest of the ribs move out. And that's the reason why you get that paradoxical movement. It's a relative lagging behind of the flail chest, which gives that paradoxical movement. That segment is not moving at all. The reason why I'm saying not moving at all is the next thing which you understand. That segment, behind that, there is pleura and the lung. So a whole segment of the lung does not move either, does not inflate. Therefore, in that area, the CO2 starts climbing up. That's the reason why that early respiratory failure settings are, they start getting tachycardia first, where the air is trying to breathe more and more by pumping of the heart so that the lungs will breathe better. The tachycardia, this results in tachypnea, the buildup of carbon dioxide, and slowly and steadily there's respiratory failure. That's the sequence of event that comes up. So what we do sometimes in the casualty, as an emergency treatment, give a little local under the rib, catch hold of the flail segment and pull it out and give a traction on this. So what happens, the flail segment doesn't lag behind, it comes out Though it is not moving, the rest of the ribs can at least push the lungs out passively. That's the reason why, till the time help is available, you can put this towel clip and pull it out. Got my point? So full flail segment can be used this. That brings to the next question. What is the actual treatment of a flail chest? So this flail chest treatment is very simple. Remember in the olden days, we used to think that is a fracture, go down and fix the fracture. So we used to take the patient up for surgery, fix it with steel wires, but by the time we take him up for surgery, he's already compromised, respiratory compromised. They go on a ventilator, sometimes most of the people used to die. So they said this is not the actual method. So then they said, why if patient, I cannot lift the rib out, why can't I blow the lungs from inside? And that's why they came up with the idea that put in an endotracheal tube and give an IPPR, intermittent positive pressure respiration. So what you do is that you force that flail segment out by blowing into the lungs. So lung will get oxygenated also. Now then they will say, how long will you keep the patient on ventilator? Because endotracheal tube, he's not going to let you put it inside. There's a lot of discomfort. So you go to sedate him, anesthetize him before you can put that. And you can't keep on keeping him under anesthesia. Because he comes out of that anesthesia. Again, you got to keep on giving. So they said, why don't you do a tracheostomy and put the patient on IPPR? So he's comfortable. So the treatment was set. All tracheostomy, all patients with flail chest, the best treatment would be tracheostomy IPPR. Now comes the question, how long will you keep it? They said till the rib starts healing. The rib healing takes minimum at least 3 to 4 weeks for the callus to form and the rib to join. It's a membranous bone. It's not a calcaneous bone. So remember, it takes about 3 to 6 weeks. And that 3 to 6 weeks, you're going to keep on ventilator. Now the problem is that when you keep on ventilator in IPPR for 6 weeks, he becomes a respirator addict. They get what is called as an iron lung. And when you remove at the end of 6 weeks, he just can't breathe by himself. He needs a respirator continuously. So now the present treatment is they say, let's do a middle path regime. You put the patient on tracheostomy IPPR and within 48 hours, make the patient stable with the respiratory things as is concerned. Take him up for surgery, fix the rib fracture, keep him on ventilator for 2 or 3 days more and pull him out of it. Then there is only a pain factor to be taken care of. This is called as a middle path regime for a flail chest. Got my point? Flail chest, always when you put that tracheostomy in IPPR, always remember you always go to take the patient on a chest X-ray immediately after that. The reason for that, sometimes you create a pneumothorax because the flail segment is sitting a little obliquely with the sharp edges pointing towards the pleura. So when you inflate the lung, the pleura comes out, gets hurt by the sharp ends of the rib, and you can get a pneumothorax. So medico-legally, moment you put the patient on tracheostomy IPPR or endotracheal tube IPPR, invariably it's always better to do a tracheostomy and then do a chest X-ray to see for pneumothorax. If there's a pneumothorax, put in an intercostal tube also. Got the point? So this is the treatment for flail chest.